Welcome to Ophthalmology CPC today. So today we have esteemed faculty Dr. Amit Khosla, who's going to be the clinical discussant. He has done his MBBS Maulana Azad in 1987 and MD from RPC as well as senior residency. Now, at present, he is a senior consultant and co-chairman, Department of Ophthalmology, Sir Ganga Hospital, in charge of retina lab. He has a special interest in retinal surgery. And he has to his credit several index articles, chapters, and he's a reviewer for many national and international journals. He is AIIMS member, Scientific Committee, Academic and Research Committee, DOS Secretary. And he has awards to his credit. Best President Award, President Gold Medal by Implant Society of India. And his main interest is to incorporate new technologies in his practice in the private sector. He started UVR Rheumatology Services in 2000, first FNB Retina program in North India. So now I will welcome Dr. Amit Khosla for the clinical discussion.
Good evening, everybody. Thank you for inviting me. Thank Dr. Bhavna for inviting me. I hope I do justice. Whether ocular oncologist calls a UVR specialist, it's a diagnosis, something between a confusion between both of them. So let's get back. You've got the history. 25-year-old male with painful progressive loss of vision with a duration of 6 months and an intermittent redness and watering. The patient was being treated by a comprehensive ophthalmologist, got an ultrasound done after 6 months, which revealed a mass. So what am I looking in the past history? A history of TB, a history of malignancy, or sarcoidosis, we ever think would cause a mass lesion. Systemic finding does not show any system involvement, and there is no history of suggestive of any malignancy or for TB. System examination, classically, they have given me a history that the respiratory system is normal. So in summary, the right eye is absolutely normal. We're looking at a unilateral region with perception of light, but inaccurate PR, high intraocular pressure, irisotrophy with 360 degrees posterior synechia, and the fundus not good. So when we see a mass, we generally want the fundus to be go through a multimodal imaging, but we don't have access to any of those images. The lab investigations are all normal. What would I want here extra would be a MON2 test, a quantiferon gold, would I want a serum ACE, IgG4, and maybe S100 test for a melanoma in the blood, if it's possible. That investigation I would want extra. This is the OCT, the ultrasound, which shows the inferonasal choroidal mass, but the retinal detachment is not attached to the mass. The mass is moderate internal reflectivity. Here, a few spikes I do see could be, I know this is artifact, but if there's a calcification in the retinoblastoma, this extra spike would be seen. So I would have preferred a video of the ultrasound. So I have this limited MRI. So what we do is, would you do a CT or MRI after you find a mass? MRI is better. CT would only show calcification. MRI tells us better. So T1, T2, T3, T1, T2, T1 where you have a isodense, where the vitreous is black. In T2, the vitreous is white, but you have a hypodense lesion, which enhances. But the report I got was a homogeneous, but I find that there is a scleral enhancement here also. So I would have to think about scleritis type picture with it. And I would have preferred a DWI image to have an idea of the cellularity of the lesion. The PET scan showed non-FDG avid subtle hyperdensity and no definite evidence of metabolic active disease. So basically, you're looking for a malignancy or a TB sarcoid lesion in the lymph node in the system where you want to get a clue to the eye problem. So let's get our facts again. That we got an ultrasound, which is medium amplitude, looking at a solid mass, not cystic or heavily calcified. I'm looking at an MRI, which is isodense. T2 is hypointense. That is a low water content, could be cellularity, melanin, or a fibrous sclerosis in the lesion. The homogeneous contrast enhancement says that it's vascular and a uniform lesion structure. PET scan would be FDG positive in malignancy or highly inflammatory disease, but the eye is a different organ where you may have even FDG negative in retinoblastoma and melanoma or even in TB or sarcoid. And you will have only FDG positivity when you have a invasion of the optic nerve or the extrascleral lesions. So whether the scleral lesion was the extrascleral extension of the lesion or it is inflamed is difficult to say. So from the malignancy point of view, I would think it's a low-grade malignancy. Patient who had a 6-month history, melanoma, metastasis, lymphoma, or you're looking at sarcoid TB. So key observations again, let's summarize. Left eye, secondary glaucoma, mass, anterior segment inflammation, no systemic disease. And the images shows a solid lesion with a non-metabolic active lesion. So any approach you do, the classical pathological teaching is look for neoplasm, primary or metastatic, infections, inflammation, or a vascular lesion. And the key lesions are that it's a unilateral mass. So let's go one by one, think of the various differential diagnosis. I know we are doing a CPC, the diagnosis will be rare, which not be in our thought process, but let's go one by one. So choroidal melanoma, we were taught, is rare in India, but yes, it is seen. But the only thing is that the T1 is generally hyperintense. If it's an amelanotic melanoma, yes, you can have T1 which is isodense. But T2 hypersensitivity, the other features fit into a choroidal melanoma, only the age and the T1 gives us a contrary view. Yes, I would want a biopsy, I would want S100 test to give me better clue of likelihood of a melanoma. Choroidal metastasis can be unilateral and maybe single lesion or multiple lesions, but the MRI response is variable. Since our whole discussion is based on the MRI, sometimes the MRI may fit into the diagnosis, but it would suspect a systemic lesion also with it. The only drawback is that PET scan, sometimes small lesions do not get picked up on the PET scan. Intraocular lymphoma is called a masquerade, generally presents in elderly people as uveitis, unlikely at this age, but yes, the lesions on the MRI can be suggestive. And really, it gets such a big mass, but generally you see small multiple lesions in the retina. Retinoblastoma of the young, you will see it with the high reflectivity on ultrasound and the variable intensity because of the calcification. Unlikely at this age, but yes, it is possible. But if you have a choroidal mass of a retinoblastoma, overlying RD would be present. Unlikely to have a RD in a different part. Now let's come to infection. In India, everything you do, you must rule out TB. So choroidal tubercles or tuberculoma, let's go into detail. Does it fit in? Yes, it fits in with a chronic inflammation. It fits in with the mass. But the T1 image is iso-intense. Sometimes you have a necrosis, cases necrosis in the center, and you may not have a homogeneous enhancement, but the sclera shows inflammation. So scleral inflammation can be intensity to the malignancy or a scleritis associated with tuberculosis. You may have small lesions, maybe non-FDG evident PET scan. So you have to keep an open mind. Toxoplasmosis is there, but it is rare in such lesions. It can fit in, but it's a low option because you generally would have a lesion in the vitreous in the beginning, would not have an anterior uveitis, rarely. So fungal would not have such a long history, but small masses can come up with candida and other lesions, but they would look differently on the ultrasound. Rare infection like nocardia, bartonella can also cause small lesions, but the patient doesn't fit in because of the long history and no other systemic findings which are positive. Rarely you will find these patients isolated in the eye. Again, sarcoidosis fits in because it's like tuberculosis, can cause inflammation, can cause a mass, but generally it would be bilateral. You'll have some systemic findings, some lesions, some fibrosis in the lung, somewhere in the lymph node. An isolated sarcoidosis is seen. You can see ocular sarcoid, but having a unilateral lesion is rare. But I would keep in mind because it fits in like tuberculosis. The new kid on the block is IgG4 disease. IgG4 disease generally comes as a mass in the orbit. You rarely have the reports of having a intraocular mass, but yes, the scleritis associated with IgG4 causes a panuveitis-like picture. So you can have a IgG4 disease, which is very painful. Scleritis can be there. Next, we come to the benign lesion. Choroidal hemangioma is very common, but it will be hyper-intense on T2, and it will have exit detachment. The only problem of a choroidal hemangioma, if it's sclerosed or fibrosed, you can have a hypo-intense lesion, but unlikely. Rare entities like medulloepitheloma, schwannoma have also been reported. Schwannoma arises from the nerve, which can be from the optic nerve. though it fits into the lesion, medullopatholoma from the ciliary body, but such lesions are rare. Schwannoma would be with neofibrinosis. You have no other lesions of neofibrinosis reported with this patient. Another rare tumor is pigment epithelial tumor, adenoma of the retinal pigment epithelium, which would have this T1 isointense and T2 hypointense, but would not cause uveitis, rarely would cause uveitis. So the uveitis and the inflammation rules out certain benign tumors. So let's look up, does the finding help us make a diagnosis? That we just have the ultrasound finding, we have the T1, T2, and we have the PET lesion, but we do not have the DWI lesion with us. So the possibilities are there. All have been reported with exception. Choroidal melanoma, the T1 finding is the problem. Metastasis, no systemic features. Lymphoma is possible. TB, sarcoma, as I mentioned, and toxo and hemangioma ruled out because rarely possible with such kind of picture. So for a UBS specialist, the patient presents to me. For me, it is the dilemma is it malignancy or it is inflammation? So among the two common malignancies, melanoma and retinoblastoma. In retinoblastoma, yes, you would enucleate. In choroidal melanoma, if the diagnosis is there, you may not want to enucleate. So dilemma always patient is, why are you enucleating my eye? And if it is infectious, I need to be clear that it is infectious. I need a vitreous biopsy, or can I do a vitrectomy and go in and do a biopsy of the lesion? So that dilemma remains, and I think the treating team has done an enucleation, so they thought of a serious malignancy, but the dilemma always is, should you enucleate or not? So in differential diagnosis, in India, if you see patients with chronic uveitis, you would think of TB. As I've discussed in detail, all lesions fit in except for the enhancing with T2. And similar picture occurs with sarcoid. It is difficult. In both cases, you having no inaccurate perception of light is possible because both cases you have a vasculitis. In TB vasculitis, you have a ischemic, while sarcoid vasculitis in the eye generally is not so ischemic to cause optic atrophy in these patients. You can have a ischemic optic neuropathy in these patients also. So among the malignancies, choroidal melanoma fits in. Only the small size melanoma, one with amelanotic, may fit in. So at the end, the key features we have discussed are the age, which rules out malignancies, the choroidal mass with moderate reflectivity, solid mass, the MRI again, isointense and hypotense. So we look forward to the radiologist telling us how have we missed any other diagnosis which could have been picked up in the MR. The only other thing which I have not mentioned is the immunological diseases, Wegener's type. But really, Wegener's will cause scleritis, but may have a mass, but rarely reported masses with a Wegener's granulomatous. So the dilemma remains for ocular oncologist: should we enucleate or should we do a FNAC? I think that Dr. Bhavna Chawla will tell us. Thank you so much for the patience.
So finally, your differential diagnosis, sir?
Melanoma and inflammatory sarcoidosis. That's the common. Here, I mentioned IgG4 are there.
Okay, so now I'll invite Dr. Sanjay Sharma to discuss the radiology findings.
Thank you. I've had a look at the representative images of MR that was shown to me, which had T1 and T2 weighted images in standard axial sections and post contrast. So as you described, evidently it did show intraocular mass on the left side, which was iso-intense on T1, moderately hypo-intense on T2, and was brightly enhancing. And what you showed as a separate enhancement of the port next to a mass, which I feel could be an averaging. When you have a mass projecting into a globe, and if you cut it in axial sections, so there could be a section in which they appear separate, but it would actually well be a part of that whole thing. After all, it has a base. So for me, it wasn't separate. It was one single lesion, and to me, that was probably averaging. In terms of diagnostic possibilities, I think radiologically, in terms of prospective diagnosis, we give a limited differentials. You described them all. You spoke about melanoma. Of course, it tends to be the most common lesion. in the adults, intraocular lesion malignancy in the adults. Hemangioma does come in the differential, although the morphology is very unlike that. And then metastasis is something which we do consider in all intraocular masses, which may or may not be FDG avid, and this wasn't very FDG avid either. So hard to nail the diagnosis, but I will keep these differentials, which you've already described. Frankly, nothing more to add.
Now I'll invite Dr. Bhavna Chawla to talk about the operative procedure.
So ultimately, it all boils down to what the ocular oncologists did and why did they enucleate if these were the differentials. And so we are responsible for answering that question. So here in this case, we have a 25-year-old adult. So one of the things that we look into clinically is what is the visual status of the eye, which is quite important when we take a decision regarding enucleation. So in this case, the patient had inaccurate projection of rays, only perception of light. The other thing was that with all the investigations and imaging that we had, we could not rule out a malignancy. Now, malignancy in this age, of course, it could be adult onset retinoblastoma or it could be a choroidal melanoma in a younger patient. We've had cases of both. Whenever we have been sure of the diagnosis, in this case, we were not sure of the diagnosis, we couldn't see the fundus. But whenever we have been sure of the diagnosis, there also we've had cases of, melanoma, even in adolescents, like 15, 16-year-old patient, ultimately whom we thought that it could have been a retinoblastoma, turned out to be a choroidal melanoma. And on the other hand, again, retinoblastoma in young adults. So these two are, as we all know, that they are highly malignant tumors. And in this case, we can't see the fundus. The vision is very poor. So ultimately, it just boils down to three possibilities that we can offer the patient. One is that keep the patient under close follow-up. That has a risk that the tumor may grow, the mass may grow, and it may come up to us, with extraocular extension. The other thing, and some patients are not even able to do diligent follow-up, so that's also a problem. They come from very far. So that is one thing that we take into account. The other possibility that we could have done was an FNAC. Now, why didn't we do an FNAC? We had no view of the fundus in this particular case. And then again, when you're suspecting a lesion like retinoblastoma or melanoma, if you're putting a needle inside the eye, there may be risk of extraocular spread and metastasis. So that is another risk. The third, of course, is enucleation. Enucleation is an irreversible procedure. We all know that. And we always have this in cases of diagnostic dilemma that what if it doesn't turn out to be malignancy? So we, in such situations, an informed consent becomes very important. So we explain the situation to the patient and, depending upon what the patient chooses of the three options, we offer that treatment. So in this particular case, the patient had a painful blind eye and he did not want to take any risk. And we did tell him that there is a possibility that it may not turn out to be a malignancy. You can just be under close follow-up. But he somehow opted for enucleation and he said that, no, I just want to get rid of whatever it is. So we told him that the final diagnosis will be on histopathology. So over to Professor Kashyap for the final diagnosis.
Okay, before I start the pathology presentation, audience, if anybody has any differential diagnosis, any other thoughts? Okay, so we move on to the pathology. We'll congratulate Dr. Amit for an excellent discussion. Now let's see. Okay, so this was the requisition form that we received, a 25-year-old male patient left eye enucleation. He had diminution of vision for 5 months, and there was a choroidal mass. So query malignant melanoma. That was the diagnosis that was offered. So we received an enucleation specimen which was slightly distorted, and you can see over here there's a small mass measuring 7 by 9 millimeters. So this was the enucleation specimen that we received. And now coming on to the microscopy of this lesion. Now this is the low power. At low power you can see that there's a cellular lesion. There's a cellular lesion with alternate microcystic areas, and there are numerous blood vessels. Now going on to the high power, you can see this is the low power of the blood vessels, and when you go on to this, you can see this glomeruloid pattern of blood vessels congested with RBCs. And also hyalinized blood vessels were seen in the lesion. Now to tell you that there was a total retinal detachment. You can see the retina over here, and the choroid was normal. The mass wasn't arising from the choroid. This is the optic nerve, sclera over here. This is the choroid, and as you trace, this is the optic nerve, which was normal. So the optic nerve also was normal. And this is the low power, and when you go on to the high power, this is the retina, and the mass was arising from the retina. So this is the retinal degenerative changes and mass arising from the retina. Now when you go on to the lesion, actual lesion, these are long spindle shaped cells. You can see polygonal to oval shaped nuclei. And there's a fibrillary pattern. This is a different kind of a pattern, fibrillary pattern with numerous blood vessels in between. And here there is this microcystic pattern, lesion. In addition to the fibrillary pattern and long processes, which pyloid processes, which we also saw these Rosenthal fibers, which are degenerated eosinophilic clumps of intermediate filaments. Here again you have these Rosenthal fibers, and here there is this eosinophilic granular bodies. So here there was some calcification, microcystic areas, and this is the lesion. There was minimal pleomorphism, as you can see, some hypochromatic nuclei, but no mitosis could be seen in this lesion. So, as it was thought of choroidal melanoma, we ruled out that choroidal melanoma since the lesion wasn't arising, and metastasis, of course, is ruled out because it occurs at an early age group, and there were no epithelial components. Retinoblastoma, yes, they do occur in less than 5 years of age, but we have seen adult onset retinoblastoma, which is highly cellular tumor and presence of rosettes are there. So we considered retinal astrocytoma. So resorted to immunohistochemistry, this is the GFAP, glial fibrillary acidic protein, strongly positive. Synaptophysin was also diffusely and strongly positive in the lesion. S100 was also diffusely and strongly positive. Then we have CDKN2A, which was positive in this lesion. Atrax protein was also positive. It shows nuclear positivity, which was there in this lesion. HMB45 we did just because the clinical diagnosis of melanoma, that is negative. OLIC2 was negative. SOX10 was negative. So my final diagnosis was an intraocular pilocytic astrocytoma based on the morphology and the immunohistochemical features. This is a very rare, low-grade, slow-growing benign tumor, mostly seen in children, but young adults also it has been reported. They arise, the most common location is the cerebellum, hypothalamic region, optic pathway, and the brainstem. WHO, it's classified as grade 1 neoplasm. Generally, 20% of them are associated with neurofibromatosis 1 which our patient wasn't associated with, and it has an excellent prognosis. Long-term 10-year survival rate is 95%. Around 70 to 80% of cerebellar pilocytic astrocytomas, they show KIA1549 BRAF fusion, which was done in our case also, but which was not positive. So it's not positive in all the cases. And so these are the lesion that I showed you earlier was hair-like. They're long hair-like processes. That's why the name is pilocytic astrocytoma. So on review of literature, I found an orbital tumor associated with microphthalmic eye and colobomatous cleft. So this was an 11-year-old boy with congenital microphthalmus of the right eye, gradual protrusion of the ocular prosthesis. So after removal of the eye, the orbital soft tissue mass, they had seen a gliotic mass, which was diagnosed as a pilocytic astrocytoma. And what they said was through the colobomatous cleft in the eye, the tumor spread into the orbit. So this is also a very rare case associated with microphthalmia. Another optic nerve pilocytic astrocytoma was reported with retinal involvement. This was a 30-year-old male, and the MR revealed an optic nerve tumor basically, and which involved the retina, but not per se arising from the retina. Then there was this ocular oncology pathology in 2016, primary orbital cystic pilocytic astrocytoma. This was a 6-year-old female who presented with right-sided proptosis with a well-defined intracorneal mass. And during the removal of the lesion, they said it was separate from the optic nerve, no communication with the brain. So this was a pilocytic astrocytoma, and what they said was the tumor was arising from a developmental brain heterotopia. That's why they had this orbital cystic pilocytic astrocytoma. So these are some of the rare cases which have been reported. And pilocytic astrocytomas, there are a couple of cases which have been reported arising from the optic nerve. So none from the retina. So probably this is the first case which is reported from the retina. So thank you. Now I think I'll ask Dr. Bhavna to talk about the follow-up.
So now that you all have the diagnosis, I have nothing much to add except that I mentioned that treatment was with enucleation surgery, and we did a primary implant. We put an implant to replace the volume loss. And then, of course, we have already talked about the histopathological surprise. So once we got to know that this is the diagnosis, as Professor Kashyap has already discussed, we did the ophthalmic literature review to see that, how often it has been reported. And we just found these isolated sporadic case reports. So here, as she already mentioned, that in 3 of the cases, it was reported as an orbital tumor, and in 2 cases, it was reported as a tumor of the optic nerve. But in this particular case, it was from the retina. So I'll just skip this because she's already talked about this. So then what did we do? So from the clinical side, once we knew that this is, we're dealing with a pilocytic astrocytoma, like neurofibromatosis type 1 is the most common association, and the other systemic association can be tuberous sclerosis. So the patient was again, re-looked at, we again went ahead with some systemic workup just to be sure that there are no other systemic signs suggestive of this disease, but nothing was found to be positive. And so we just kept the patient under follow-up. He was fitted with an artificial eye post-enucleation. He was explained what his diagnosis is. And now we have a 2-year follow-up of this patient. The patient is disease-free and wearing a prosthetic eye. So just to sum up, given the rarity of this condition, the diagnosis was a histopathological surprise. And as Professor Kashyap has already highlighted, what was even more unusual in our case was the absence of both orbital as well as optic nerve involvement in the pilocytic astrocytoma. And to the best of our knowledge, such presentation in a case of pilocytic astrocytoma has not been reported so far. Thank you.
Any questions from the audience, or we just sum up?
Maybe or maybe not.
Yeah, it's a mic. Yeah.
If we did a FLC or some sort of histology of this tumor before the surgery, that this is a benign fluid tumor, so we still have knowledge with the or we manage differently.
Yeah, then the management would have been different, I think, once we knew that it was a benign tumor, maybe.
Actually, this
It's very difficult actually on FNAC to diagnose on FNAC such a case. It's very difficult. Yeah. No, it wouldn't have been. Yeah, because you, right from the beginning, you were thinking of a malignant tumor. So,
visualization, because we can't view the fundus, we are taking a risk of putting this is a very patient.
no, we removed the lens. Yeah, we removed the lens because it's very difficult to cut with the lens. No, we just remove the lens, and we take serial sections of the eyeball. So while cutting with the microtome, the lens is very hard, becomes very difficult. The blade also has serrations, and that also goes out of order. So we remove the lens generally, unless the lens has some pathology and we need to study the lens.
Do you think melanocytoma will have been information? Melanocytoma.
MR, they say that typically if it's a pigmented lesion, it tends to show even brightness and people dark. This is the signature, MR signature. But most tumors that I have encountered, never. We can only say that optical melanoma would be most
No, in this case, melanocytoma doesn't arise. It's highly pigmented lesion. So melanocytoma is, yeah, okay. The radiology point of view. Mushroom shaped.
narrower base and less like vascular lesions which tend to be more like we located more in the segment lesions. So here are the two most common differences and of course CNS lymphomas are primary CNS
Yeah, they are very rare.
most of them are primary
One more thing, Dr. Sajay, could you make out this was arising from the choroid radiologically?
I think so. It's very hard to distinguish the retina from choroid on. Given that it was enhancing, given that it was, looking so by again by
A
You need
melanotic
a video, ultrasound video, where you can see the different angles, you can see the core.
Yeah.
Otherwise, the vision will shadow of the core. So for a subretinal mass, as I mentioned, would have been a detachment at the same point. It didn't show a detachment at the same point. It's something new for everybody.
So one vision that is developing and very closely linked has been challenging for us also.
Yeah.
Intraocular.
intraocular.
That's the only thing. But then again, in that also, is the histopathology.
Yeah, it's going to be histopathology. In schwannoma also, it's the diagnosis by histopathology. The mic is
retinoblastomas which have a spectrum of enhancement from non-enhancing to heavily enhancing, brightly enhancing. So as a marker, enhancement is a marker of degree of malignancy or malignancy itself. This one was very brightly enhancing on MR. At the same time, didn't showing ability on PG. So it probably didn't have so much metabolic activity because
yeah benign tumor.
enhancing
Yeah, it was very highly vascular. It was
they are enhancing.
pilocytic. Yeah. Yes, molecular was negative. Yeah, the fusion here was negative. Yeah, Dr. MC Sharma helped me with the immunohistochemistry and the molecular work. So unfortunately, that was negative. But we could still get the attracts and the other immunohistochemical findings.
One more question. Did the tumor arise from the inner or the outer layer of the retina? So did it blind the retina off because it was from the outer layer? Or was it subretinal? And which layer of the retina was the tumor? Because there was a retinal detachment.
Yeah, retinal detachment was there. So actually, it was very difficult because the whole thing was detached, and once you get the sections, the whole thing is distorted. So sometimes it becomes very difficult. And as you could see, the retina was totally like degenerated. You couldn't make out the layers, different layers.
And do we have astrocytes in the retina?
The neurosensory layer, it has risen from the neurosensory layer as far as the retina goes. That is the only layer which can give rise to this lesion.
Diffusion weighted images are made.
No. Diffusion images itself basically reflect the degree of cellularity. Compacting the cellular range, diffusion would be restricted. So I don't think that the balance is because from the animal.
But generally, for a melanoma, it is worth the while.
In melanoma, they are different. But I think this is different.
Okay, audience, if anybody has any questions.
I have a question for melanoma. If you have a melanoma,
So
can this melanoma MRI?
radiological diagnosis on MR will be largely dependent on the size. Tumors, for example, retinoblastomas, we cannot give it a cliche that if you have find smaller lesions, which will not be picked up on MR. So essentially, size dependent. The resolution of the image. So resolution of MR doesn't allow us to exclude a diagnosis of a pathology. And so I would be is the case with and actually, yes, sometimes the lesions are very not very evident to see. They become more manifest in the great one. Typically, they go to the melanoma. Regular image in your own pick them up. If you see a motor science, immediately you will pick up in hand. So, enhancement in the size.
So when we order MRI, any specific things we will say, look for this or for the resolution?
No, most if it's very done, should give it in the answer.
The test or make a difference, you need to treat it.
I think the resolution is all right, but it's not resolution. It's just that when achieve a similar resolution, it takes more time. It's a great resolution and time. So we can achieve the perfect with a shorter time.
It's a
We need to
benign.
be careful about the other eye.
It's a benign tumor, and if it's removed surgical excision, total surgical excision, there's no chance of recurrence also. I don't think about the second eye, bilateral are not.
We invite our Chief Professor Radha to say a few words. Yes, I'd like to congratulate Bhavna and the entire Ophthalmology team for the fantastic and fascinating case, and of course Dr. Amit Khosla for agreeing to come at such a wonderful, differential diagnosis and detailed discussions in a very systematic way, the way you mentioned it. And of course the entire team, Dr. Sanjay and Dr. Seema Kashyap and everybody for putting everything together so nicely. Thank you and congratulations. I wish more people had had the opportunity to attend, but I think simultaneously some things are going on in our business. Everybody couldn't be here. Thank you everybody and congratulations.
Thank you, everyone.